Hi everyone, I will be beginning to play the intro video and then we will begin the discussion. Over to you, Sagar.
Very good evening to all of you, and we would like to welcome you to this session of the Sankalp Global Summit in 2022. Today, we are here to discuss on a very critical topic for Indian health, innovating financing for primary healthcare in India. Today, we have the honor of having some of the best minds in India to deliberate on this very important topic and the way forward for it. We'll be discussing the various facets on how innovative financing has worked in India so far and the way forward as well. To speak on the topic today, we have a seasoned panel of experts from across the health domain. And the moderator for this panel will be Dr. Rajat Chabba, who is the Senior Technical Advisor for Global Solutions and Innovations at Japaigo from Baltimore in Maryland. The panelists for today are truly the who's who of the health world in India. Headlining the panel is Dr. Indu Bhushan, who of course, as most of you will know, is the ex-CEO of the National Health Authority. Next, we have Mr. Abhishek Gopalka, who is the Partner and Managing Director for Healthcare at Boston Consulting Group in India. We have Dr. Ajay Nair, who is the CEO of the Swasth Alliance, Mr. Ajay Sharma, who is the co-founder and the COO of the Desh Clinics, Mr. Madhav Joshi from the CEO of India Health Fund, which is part of the Tata Trusts, Ms. Anjana Narayan, who has had global experiences across the health industry and now is the managing partner for 24/7 Strategies LLP. And finally, we have Krisha Mathur, who is the founder of Clinic Didi. I will hand over to Rajat now to start the discussion, and I hope to have a very engaging conversation with all of you. Thanks. Over to you, Rajat.
Thank you, Sagar. And greetings, everyone. And we welcome you to our discussion today at Sankalp Global Summit 2022. In India, nearly 65% of healthcare is spending is out of pocket by individuals. The remaining 35% is fragmented and comes from a number of central and state governments, funds, and insurance companies. The unprecedented healthcare crisis caused by the pandemic has brought a number of concerns about effectiveness and sustainability of healthcare system to the forefront. To add to it, the fiscal expenditure on public healthcare is only 1.4% of our GDP. Primary healthcare also encounters twin challenges. One of a high price elasticity, which is a serious concern that consumers across income categories may undervalue or underconsume primary care and may value expenditures on medicines more than they value advice from the physician. The second key challenge is also around the high switching behavior. For a provider who intends to offer high quality primary care, this kind of switching behavior makes it difficult for the provider to ensure continuity of care and can significantly impair the financial viability of the services that they provide. And in our context, the switching behavior is perhaps far more significant than the high price elasticity because it fragments the market and the small amount the patients are spending on primary care. While the COVID-19 pandemic was a wake-up call for most of our health systems, and the topics of health financing gained great salience, India has been one of the front runners in testing out some of these new innovative models. We have tested out innovative financing approaches in maternal and child health, education, and tuberculosis, among others. While some of these models have shown promise, have proven to be effective, there have been challenges that come across as well. One of the domains that innovative financing needs to be deliberated is its vast potential to create meaningful engagement models with the private sector health providers in our country, who are a major source of health seeking for Indians. The session today will discuss on some of these things that have worked around innovative financing and what are the next steps and the milestones in our roadmap to make effective use of upcoming tools and methods that exist. We will be listening to our thought leaders about how the multiple and ever-growing health challenges in India can be tackled by using an inclusive, consultative, and multi-stakeholder approach. With the last decade, it is also important to understand there have been some tectonic shifts. The growth of technology, digital tools has created unprecedented opportunities for us to move forward and create ways and partnerships that can change the future. Also, the increasing awareness level among the policymakers and the greater shift toward better public-private partnerships creates conducive policy environment and ecosystem for us to move forward. Today, I would request our esteemed colleagues to focus on two key questions as we move forward. One, is it viable for us to actually eliminate out-of-pocket expenditure totally, or should we focus on reducing it? How can we strategize our resources well, given our current reality? And second, considering the critical role that private sector plays in complementing the public primary care services, are innovative financing mechanisms a potential solution to ensure equitable participation across public and private sector? So without further ado, I would like to welcome and introduce our panel to you. First on our panel, I would like to invite Dr. Indu Bhushan, who scarcely need an introduction. Dr. Bhushan was the CEO of Ayushman Bharat Yojana and the National Health Authority with the Government of India. Until his appointment as CEO, he served as the Director General, East Asia Department of the Asian Development Bank. He has held multiple positions with ADP. Dr. Bhushan, I would request you to kindly give your introductory remarks to us. Thank you.
Well, thank you very much, Rajat, and thank you very much for Sankalp 2022 for inviting me to this workshop. So you asked two questions, and I'm actually going to be answering 4 questions or presenting 4 questions for innovative financing. One, why do we need innovative financing? Why are we here? Second, what do we need to do in innovation to address the problems that I addressed that need to be addressed? Third, what are the different approaches which have been tried? And fourth, what are the challenges in innovative financing? And so just going back to the first question, that why do we need innovative financing? Basically, there is not enough money in the sector. We know that India is one of the countries where we're spending least amount of money in health. We are, I think, 191 countries for which we have data. We rank, I think, in bottom 5 percentile. So, of course, we need to get more money, and government needs to put in more money. Philanthropists and other financiers need to put more money. And why are they not putting more money? One is that they need some comfort that whatever money is being put, we are getting something out of it. So not only we need more money for health, but we also need more health for money. And to give that comfort to these financiers, these donors, we need to have systems in place that can provide that. And what happens in the sector is that till the time the check is written by a financier or donor, we are running after that financier. Let it be it any aid donor, grant donor, or even World Bank, ADB, those organizations which are providing loans. Till that time that they approve the project, they write the check, we are running after them. But once the project is approved, they are running after the implementing agencies that you select you implement the project in the spirit that we had agreed to. And the problem with health sector is because the soft sector, there is that in the economics we have this typical principal agent problem, where principal and agent have that relationship, but all the actions of agents are not visible to principal. So aligning the incentives and aligning the incentive of agent with the principal is the key in terms of innovative financing. So what kind of innovation we need to have? Next slide. So we need to have innovations which align the incentives of financiers and implementers. So whatever financiers want and implementers have agreed to do, we should be able to assure that. And the funding should be contingent on achievement of some agreed results, at least to some extent. That is the key. And we also need to be, we need to understand that in health, it's not only the delivery of services, but the quality of services, which is extremely difficult to quantify. And to ensure that we have to have incentives that quality services are provided, and quality services are provided to the people who that we intend to. It's not to anyone, but maybe we have a target of poor people, vulnerable people, tribals, other group, elderly and women. And so we need to ensure that those people are getting the money. So how do we go about it? There are some of the things that we've been trying actually address those problems. And I must say that Ayushman Bharat or schemes like Ayushman Bharat, which support demand side, already have that innovative financing element in them. Because if you just consider that for last 75 years, most of our schemes were what we call supply side schemes. So we build hospitals, we will provide services, and we assume that those services will be available to poor people, right? So that's a article of faith, and all these big hospitals that we have created. We know that sometimes poor people have problems in getting those services. But in a demand side, so hospitals will get payment only if they've provided service to a poor person who's identified as the beneficiary of Ayushman Bharat, right? So therefore, this is already an innovative approach, that if we can make grants to each hospitals contingent on the fact that they are going to be providing services to poor. For example, AIIMS currently gets more than 4,000 crores. And out of those 4,000 crores, we say, okay, you'll get 2,000 crores as a grant money, and remaining 2,000 will be contingent on if you provide services to people in Ayushman Bharat. And of course, that's very clearly identified. So that is already an innovative way of financing health services, which will ensure that these hospitals prioritize poor people, right? Other thing that have been tried is a loan buy down mechanism, which I had led in Asian Development Bank, where we were providing loans to many small countries, largely in Pacific Island countries, who did not have good debt repayment capacity. But of course, they needed resources, they needed financing, and so the loans were given. At the same time, in Pacific Island, Pacific area, Australia is a big donor, and they wanted to provide donor money as well, in grant money. And they were struggling with the same principal agent problem, that if they provide the money was not being used for the purpose that they were providing money for. So we had understanding with Australia that, okay, we will provide loan to the country, and if the country implements this project in the spirit that we have agreed, so instead of country paying back the loan to ADB, Australia will pay back the money to us. If this project is not implemented well, then of course country has to pay back money to us. So in this case, there is an incentive for country to implement the project well, so that their loans are written off by Australia. Australia was also happy because they know that their money is going to support something, which is, and they'll get those outputs or outcomes they want to have. And we, of course, we get most development effectiveness, because we know that money achieving those outputs and outcomes. So it was a win-win-win situation for lender like ADB, recipients like say Tonga, Tuvalu, and those small countries, and grant financiers by. So this can also happen in primary healthcare. Other thing that we have, you mentioned in the background paper, results-based lending, or what we call usually cash on delivery, that you don't provide the money till they have achieved some outputs or outcomes. So maybe you provide some seed money, and subsequent money is provided only after achievements of certain results, or we say, so some results in the matrix is agreed, and we call them disbursement link indicators, DLIs. So once those indicators are met, the disbursement takes place. You mentioned about Rajat, about technology. There could be e-vouchers that we could provide e-vouchers to beneficiaries, and that money can be used only for that particular thing. For example, let's say in primary healthcare, it's about the prenatal care. And if you want to go and use that e-voucher for prenatal care or delivery in an institution, you can use those, and that money will directly, e-voucher could be given to provider, and they can claim the money. It could not be used for anything else. So it's very direct delivery. It could be used. And of course, you have mentioned about the concept of development impact bonds and social impact bonds, and one such thing has been tried in Oathcrest in India. I don't know what the results have been, but so there are some of the approaches that have been tried. But again, the last slide, nothing is simple, and especially in the health sector, there are a lot of problems, and most of these approaches that we tried are outside the health sector because of many problems. One problem is that health outcomes are not only linked to how well you implement the scheme, but also other social indicators. So infant mortality rates or many of the health indicators are contingent on the nutrition levels, status of women, sanitation, and many other things. So maybe you're doing a great job, but still you couldn't achieve those outputs and outcomes, and that. So it will be unfair to link those efforts to the grants or resources, because although you're doing maximum effort, but still not achieving outputs and outcomes. Second thing is that sometimes there is a gap between what efforts you put and the outputs and outcomes. You start building strong health sector and systems, but it will take some time before you will see impact on outcomes. Maybe you can get some output. So for both first and second challenge, I think one has to take a small slice of health sector and something which can be directly linked to effort, and it doesn't take time. It can be assessed, identified, or measured in an objective way. So that could be one thing. And of course, there is a problem in measuring outputs and outcomes on timely basis. Of course, we have these surveys which are spread out over 5 years, then it makes it difficult for using some of the approaches that we have. But again, something could be done if we are taking a narrow slice. But the problem is that if we take a narrow slice and provide financing for some very small part of a health system, then you're contributing the already fragmented health sector, where we have a lot of vertical programs and financing is there for a small part of the health program rather than strengthening the whole sector. And that problem will remain if you try to address other problem. So with this, maybe I'll just hand it over back to you, Rajat, and thanking you again for inviting me to this this meeting.
Well, thank you, Dr. Bhushan. I think you, I made note of a couple of points that you highlighted, which really stuck with me. I think around the need to align the incentives between the financiers and the implementers across the system. And at the same time, the tension that the system has in terms of the challenges that can be created through the interventions that we do. I think you spoke about how we run the risk of fragmenting the health system, an already fragmented system. So I think I'll request everybody to hold some of their thoughts and put some of their questions in the chat as well. but I'd like to move on to Abhishek. Abhishek leads the BCG's work in public health in India, and he has over 14 years of experience in strategy advisory, working with both government and private sector clients uh, at multiple levels, central, state, with multilateral agencies, foundations, and focusing on a host of topics: governance, digital, service delivery, human capital development, public-private partnerships, and most recently on COVID-19 resilience response. So, Abhishek, maybe I'll hand it over to you to see that at a systems level, what have you seen and observed in your experience that is critical for us from an innovative financing standpoint?
Thank you so much, Rajat, and thank you so much, everyone, for inviting me to this event. I'll start by just echoing what Dr. Bhushan said, and the two phrases that he used, right? More money for health and more health for the money. I think the second one, that more health for the money, to me is actually pivotal, because you will get more money for the health once the system, the financiers have more confidence that you are getting more health for the existing money. So I actually wanted to build on that and talk about specific use cases in the context of primary care that we are beginning to see. And actually, the last couple of years have been very pivotal in terms of making many of these things a reality. You know, typically when we talk about healthcare, we talk about that iron triangle, access, quality, affordability. I genuinely feel that now we can start to think of them not as trade-offs, but as starting to think about them in parallel. So, for example, it has to be access and quality at scale, affordable, and not that, Hamara Desh will first work on access and then we'll think about quality, etc. So in that spirit, the first category of use cases that I really wanted to highlight in the context of innovative financing in primary care is really around pay for performance. Now, this is not new as a concept at all, but we are now beginning to see application of it. And I do feel there's an imperative for both states and the development sector more broadly to really push much harder. So, for example, health and wellness centers, there is a component around performance-based incentives. In other words, there is an opportunity for the team, medical officers, CHO, ANMs, to really get compensated for the kinds of services that they're providing to the end beneficiary. So if you assume that you have a strong data system with verifiable data, how do we unlock performance-based incentives if the data is verifiable and reliable? Some states have started experimenting with it, but I think a lot more can be done. And to Dr. Bhushan's point, we should not be fragmenting it. The performance-based incentives has to be a function of a balanced scorecard of multiple different services. And only if you're delivering on those, do you get that extra incentive. This can also be a great way to attract doctors and other medical personnel back into the public delivery system, which has, of course, been a long-standing challenge. I also feel that these services or these kind of thinking can be extended to frontline workers. For example, one of the use cases that was tried out during COVID was around e-rupee, which many of us would have heard of and come across, especially in the context of COVID vaccination. Dr. Bhushan talked about vouchers and how that can be used. The ABDM infrastructure, along with smart payments, makes e-rupee possible, which can be linked with basic services. Think about it. When you take an Ola or an Uber, you get an OTP, and you use that OTP to verify that you have received those services. Can we use similar thinking to empower, rural women to say, "Mere bacche ko wo tika mila hai, I provide the OTP, and that's trying to solve the principal agent problem again." To say that yes, those services have indeed been delivered. And so, long-standing payments of ashas and things like that will no longer be an issue, because there is almost a dynamic, crediting of her account as she's delivering the services. So you're able to verify the delivery of services, and you can make payments much faster. So again, just two examples of pay for performance. The infrastructure exists, a lot of scope and potential to push forward. That's the first category that I want to highlight. The second category that I wanted to highlight is how innovative financing can be used to leverage the power of startups, right? Again, this is not a conversation that would have been possible 10 years back. But just given the kind of involvement that they've had, again, not just as B2C, but even during COVID, I genuinely believe there is an opportunity to leapfrog. And we can really think about how do you mainstream the services of startups in the context of primary care. I would again use two examples here, drugs and diagnostics. Many of these startups are really increasing their reach. They're not just metro tier 1 players, they're getting into tier 3, tier 4, rural, the coverage of zip codes. So can we have, service level agreements, which we use to get into partnerships, genuine partnerships. We shouldn't be thinking about them as vendors, but genuine partnerships with the private sector to be able to, deliver much higher quality of services in the primary care context, like drugs and diagnostics. And it's really interesting to see, many states, municipal corporations starting to experiment with some of this. Previously, it was being thought of just in the context of, let's say, 3PL, third-party logistics. Now people are going a step forward and saying, if we as out-of-pocket paying consumers can pay for our drug delivery to the doorstep, why shouldn't government partner with that? And does advancements in logistics bring down the unit cost enough to make it possible? So just as that's a second category to say, how can you use innovative financing mechanisms to be able to partner with startups and innovators? The third one, of course, is the holy grail, which is paying for outcomes. I will first admit that there is the challenge of the verticalization and further verticalization that Dr. Bhushan talked about. So with that caveat, I will say that it's a powerful instrument. It will have to be used with a lot of care. My own view is areas like infectious diseases actually lend themselves very well. As we think about our goal as a country to eliminate tuberculosis, if we think about the 95 goals in HIV, these are very specific areas with very specific measurable outcomes, whether it's viral load suppression in the HIV context or TB notification in the TB context, very specific outcomes around which you can wrap innovative financing. So think about, again, combining this with the second point around startups, you can actually have end-to-end ownership of notification for a particular patient, and you wrap an innovative financing mechanism around it. So again, I admit that there are those challenges of the verticalization, but in terms of being able to eradicate some of those diseases, I think there's a lot of potential out there. The last thing I just wanted to talk about was around enablers. I think the conversation on innovative financing would be incomplete without some of the building blocks. None of these use cases will be possible, in my mind, without enablers. Three major ones I wanted to talk about. One is obvious, which is the data systems. I think having beneficiary level verifiable data systems is an absolute no-brainer. ABDM is a godsend. I think the whole nation owes a lot of gratitude to Dr. Bhushan for having got that journey started off. But if that becomes possible, it just unlocks a whole number of applications and the use cases that we kind of talked about. So that's number one. Number two is procurement reform. We've all been talking about it for a while, but again, if we do want to get the startups involved, bring in more private capital, etc., timely payments has to be a big lever that we need to get serious about. So smart contracting, escrow accounts, etc., but really making sure that we take care of working capital issues and making sure that the private sector gets more confidence to get involved. And then last is the organizational aspects. For government to be able to truly take advantage of these innovative financing levers, there will have to be new capacities, new muscles that need to be developed within government. Again, two examples. One is a fairly long-standing one around the PPP cells. How do you truly partner with startups? Again, not vendors, but true partners in this entire journey. How do you make sure that payments are on time, etc., the use case thinking, all of that. The second is almost chief technology officers. Many of the organizations that we work in on this call itself, a CTO is a very common thing. As we start thinking about the state health systems and the critical role that technology will play, you'll almost need many organizations within the health departments which are really thinking about the technology backbone infrastructure on top of which these use cases ride. So again, three major enablers: really strong data systems with verifiable beneficiary level data, without which you cannot build the use cases on top, procurement reform, and a lot of organization and capacity building in order to unlock these use cases and see the true value. So I genuinely believe that, innovative financing in primary care can be a massive unlock, and we just need to push forward on these use cases supported by these enablers. Thank you. Back to you, Rajat.
Thanks, Abhishek. I think you made an extremely powerful point around the role that social enterprises and startups can play in this space. And I think the point around drugs and diagnostics is critical, because often the insurance system is able to cover the hospital and the institutional care, but these are out-of-pocket expenditures which are often left out of that system. So maybe, and it's also a good segue for us to actually get an understanding of what the private sector role that the private sector can play for innovative financing. I think both you and Dr. Bhushan spoke about the need to have more health to create that confidence and demand. So maybe I'd like to invite Anjana Narayan. She is currently the managing partner for 24/7 LLP and serves as a senior advisor at Private Equity Pro Partners. Prior to that, Anjana has worked with GSK, Merck, and Bayer, and has created opportunities for equitable access to healthcare, medicines, and vaccines through her work. So maybe, Anjana, I'll pass it on to you to actually share your thoughts on how the private sector can actually be engaged in this process.
Thank you, Rajat. Good evening, everybody. It's really exciting to be part of this dialogue. And I have to say, I've spent my career in healthcare on the pharma, vaccine, and biotech side. It has been very heartening to attend the last 2 days of the Manthan conference, and then to be here today and listening to this distinguished panel. We gather today with a common passion to see equitable access to quality primary healthcare. And the reason is that I think fundamentally everybody understands that by taking care of primary healthcare, you're creating a virtuous cycle where you have a healthier population that leads to a healthier nation. And I know that this is a very, motherhood and apple pie statement, but actually from a common purpose standpoint and a vision standpoint, this is something that we see in the discussion today. I think I wanted to preface my remarks by also saying that while many attempts have been made around the globe with a variety of different health system mechanisms and models, there's yet to be a perfect healthcare system. All the systems have some pros and cons. And I think we have to go forward with not looking for perfection, but looking for progress. And we have to be benchmarking that progress. And I think that what we have seen, and I want to congratulate Dr. Bhushan for the work that PMJ has done and the progress that we've seen over the last 5 years. And it's been really, really phenomenal. So as was mentioned earlier, India's healthcare spending is about 3.6% of the GDP, which is far lower than some of the BRIC countries. And about getting to the 2.5% of GDP is going to take some doing. But I think we have to also remember that getting to the 2.5%, we're going to ask ourselves the question, who's going to pay for it? And how are we going to manage the expenditure which comes along with the increase in those payments? In listening to the implementers the last 2 days that came from the states, for example, Uttarakhand, where in Tehri, they have covered the entire population, regardless of income levels, with the public funding. The discussion really was, how do you sustain that spending? Also, Maharashtra, which has a hybrid system, had the same question. Insurance premiums are going up every single year. So how do you create a mechanism that is actually profitable, yet delivers on the promise of primary care? So in order to achieve the SDG goals by the deadline set by the National Health Authority, it is imperative that we keep special populations in mind, because I think you can't provide the same focus to everybody in the country. This is a very large population and we have to be very focused. And I think someone said this earlier, which is mortality of children under 5 years of age, certainly in the SDG goals, along with the health of older adults, the maternal populations, and the morbidity and mortality in the maternal areas, and also taking care of the essential workers is extremely important to consider when you're considering funding. We discuss also the devastating impact of catastrophic illness on the missing middle, along with the near poor who are almost at the poverty line but not covered by some of the schemes. And indeed, preventing diseases and making sure that primary care is taken care of, where the health and wellness centers are stocked, the telemedicine facilitation is happening, diagnostics, vaccines, and other measures are actually provided at these healthcare centers, is imperative to creating trust in the population that they can actually access these services as was intended. I think one key learnings for me, at least for the last 2 days, was also to listen to speakers who said that even if you provided all the funding, would the people come to the healthcare centers? Would they be able to trust what they are going to be hearing at these healthcare centers? Are they going to trust that they're going to get the care that is actually required? So I think we have to address both the supply side, but also the demand side in creating trust by creating the funding for these centers. As far as the innovation funding is concerned, I was working in vaccines for a very long time. And I can tell you that the putting together of Gavi Alliance was the first global outreach that I saw in terms of bringing key stakeholders together to be able to create funding avenues. The partnership model is a simple one. It's a public-private partnership. They capitalize on the sum of their partners' comparative advantages. The business model is by pooling demand for vaccines from the world's poorest countries, securing long-term funding, and shaping the vaccine market, and also procuring that they need at the right pricing. And I think what they're leveraging is the economies of scale. They were able to actually bring the volume together. I don't think in India we have a volume issue. So I'm speaking for the industry to say that actually we can create mechanisms where you can lower the contractual procurement costs by creating that leverage on the economies of scale and taking into account what PAHO, what Gavi, and other funders have been able to do, which is to really leverage the power of volume to be able to drive prices down. And this is in conjunction, of course, with working with critical partners, with the industry, in a business model that actually, it rewards working together. And this was seen actually in the COVAX AMC during COVID-19. We know that countries with the lowest incomes would have been at the back of the line to try and get vaccine doses. Of course, we're all very happy with what happened in India and how the implementation happened for the vaccines. And I was just looking at the numbers today. About 2.2 billion vaccines have been administered already in India, which is a phenomenal number, and creating the electronic records, which unlike many of the even developed countries did not happen. So very impressive. However, for the COVAX funding mechanism, there was a political will, there was an industrial will to be able to work together. There were funders, donors, and self-sustainers and self-funders that came forward. And of course, the main organizations that were working together worked together very well. So you had CEPI, you had the WHO, UNICEF, and as well as Gavi coming together to create a mechanism that would be able to get the donors' monies in, to be able to actually get procurement of the vaccines. And remember, in 2020, we weren't sure that the vaccines were actually going to be effective or even be able to be marketed at that point. But there was a risk-taking that happened with COVAX. They assured through the funding that they created to the manufacturers that actually there was a volume that was going to be purchased by COVAX. There was intense negotiations with developed countries that were in a way hoarding vaccines to be able to create donation mechanisms that would be able to get the vaccines to the LMICs. And also really from a practical standpoint, creating the readiness in countries to be able to get the COVID vaccine required a lot of muscle. They provided about 1.7 million doses into about 91 countries. They also provided 800 ultra-frozen freezers to 70 countries that had no way of receiving the Pfizer and Moderna vaccines. So there was a lot of implementation challenges at the local level that we saw being solved through COVAX. And I believe that, when you take a look at private market funding, everybody is looking for the health of the money, right? But actually, in the stage that India is in right now, while we talk about profitability in primary care, the practicality is that is going to be very, very hard to show profitability to funders. This is why, even though it's such a huge opportunity, you don't have much funding coming through for primary care. However, there is an element of putting social impact into the primary care area and inviting investors who are interested in a public-private partnership with reinforcement of volume discounts, of other guarantees that can be provided as far as reimbursement, and also creating smart contracting to be able to bring the industry to the table. Whether it is obviously products made in India, or they are products that are going to be brought from global sources. I think the supply chain will be robust if we can create the mechanisms to be able to bring the products and services that are required to the table and be able to provide the kind of care that is required in the primary care setting. I just wanted to also point out that novel funding mechanisms are already in place that we see in many of the test cases that were provided. So, for example, Samriddhi is actually mobilized a capital pool of about USD 250 million as of January 2022 in both grants and debt financing provisions to healthcare enterprises. USAID has been acting as a guarantor in strengthening a bank's ability to actually lend underserved healthcare enterprises, catering to customers, including vulnerable populations, etc. And of course, you've got the Skill India Impact Bond, which again is basically fashioning themselves as if are raising capital on the capital markets. So there is an opportunity of actually working at the ground level, trying to find social impact providers that would be interested in not just profitability, but also a social impact. So I would say that in terms of building the financing, building the innovation, working with startups to actually get primary care rolling to where we want it to be, and also the public-private partnerships, there is progress in the field, and we need to continue to work on that.
Thanks, Anjana. I think you made a couple of great points in terms of one, while it is hard to show profitability, I think there is opportunity for impact investors and different financing mechanisms to actually be looked into. And I think your point around pooling the demand and with the volume that we bring in India, I think is a great opportunity for us to explore and unlock going forward. It also, I think, provides a great segue for us to actually invite Madhav, who is the CEO of India Health Fund, a Tata Trust initiative which funds the development, de-risking, and adoption of science and technology-led solutions, which can improve outcomes in diagnosis, treatment, and prevention of communicable diseases to create impact at scale. So, Madhav, maybe it would be great to learn, I think, the challenges that we are facing and the opportunities that we see with the scale that we have in terms of how the ecosystem can actually come together. And I think you've been trying to leverage, everybody spoke about digital as well. So how do you see that those digitally enabled platforms along with financing can actually help us move forward in this space?
Sure. No, thank you, Rajat. Appreciate that. So I'm really going to focus, there's been a lot of discussion around the delivery side of innovative financing. I'm going to focus on the development of the tools that are needed to really deliver good quality primary healthcare. And that's been the experience at India Health Fund. So yes, we were set up to identify promising technology which could play a role in improving outcomes. But more importantly, we were set up to address an area of market failure, which was the non-availability of capital and financing to take promising technology from lab to market, and address the so-called valley of death, which is very different from what's been happening in non-communicable diseases. And our experience really sits in three areas. One, particularly in the area of communicable diseases, which is what I think Abhishek alluded to, there is probably a greater need for innovation as well as capital than there is in many other areas. And I think we've all now lived through the COVID experience to really understand what the impact of a poorly functioning health system can be, particularly at primary care. But underlying that is a very, very clear focus on what technology needs to be solving for. So good definition of the problem statement is critical. And with that, what we found is that it's very possible to identify the right technology interventions. But enabling them is where financing has a role to play, because a lot of developers do not have the capital, they don't have the market access, and they certainly don't have the data access that's needed to apply technology to address a problem. And that's typically where an India Health Fund-like organization is now coming in, with not just the patient capital that many of these solutions need to enable their development, but also to facilitate the right access to particularly the public health system, which enables the developers to work with the service providers from the get-go to make sure that the solutions are designed for purpose. These developers have access to the data that they need to really develop, particularly, and we spoke about digital, so maybe I'll focus on that, the digital arm of the solution. And the last leg is really from development to deployment, particularly in healthcare. There's a big black hole, which is called evidence. And that's typically where a lot of solutions, again, lack the capital and financing to really enter the health system, to demonstrate outcomes that the solution was designed for, and then create the use cases and the business cases that are needed for the health system to adopt. And that's the entire journey that India Health Fund has been enabling. And I'll quickly run you through, I think, one of the more recent examples we've had. Tuberculosis has been identified as an issue of national importance, given that our elimination goal is 2025 and we're far from it, particularly with the disruptions that COVID has caused. Early notification of TB is critical. And the limited infrastructure, particularly in remote TB endemic areas, restricts that. AI-based technology has a role to play because it can supplement limited manpower and eliminate the need for a radiologist to read a chest X-ray. The technology exists. Enabling the technology by supporting the development of the right algorithm, but more importantly, demonstrating that the algorithm works is what we've done with the Central TB Division and state governments across 8 states now. What's that demonstrated is that diagnosis time can be brought down to 2 minutes from 7 days. Time to initiation treatment is down to a day from 14 days. And the patient follow-up is much more effective because all of this diagnosis is now digitally enabled, so the notifications happen immediately. And it's all within the electronic databases that the NICSHA system provides. This wouldn't have been possible without patient capital. But what the patient capital has enabled is a virtuous cycle. By opening up market access, the organizations that are developing these algorithms now have steady revenue streams from the scanning services that they're providing, which is enabling both blended finance to come in to cover their capital costs, as well as investment capital, which is helping them scale much more rapidly and faster because, as was mentioned earlier, India has a large enough market to really demonstrate potential for this. And the fungibility of technology has allowed a solution developed for tuberculosis to be developed into a lung health suite, which is now covering not just tuberculosis, but COVID, lung cancer, and a number of other lung conditions. So that's just made it a much more capital efficient, commercially viable solution, relevant across both public and private sectors. So I think that's where patient capital can come in, but more as a catalyst rather than as a means of funding in itself. And I think that's the biggest role that we've seen innovative financing mechanisms can play in seeding the development of technology to really take it to the last mile, particularly for underserved and vulnerable populations.
I think great points, Madhav. I think a couple of points that you made, I think around patient capital and also around, I think the ability to create a platform which can then be actually, which is say technical area agnostic, right? Can actually be used for much larger purpose rather than being limited to particular disease area. And creating those opportunities are, I think, extremely critical. And it also provides me a great segue to actually move on to somebody who actually worked in patient capital. Ajay, I'm looking at you with your prior experience of working at Acumen Fund and also with your experience of co-founding one of India's first telemedicine platforms, I believe, in Mera Doctor, and currently your on-ground experience with Swasth Alliance, and maybe you started as working in rural clinics in Bombay and rural Maharashtra, right? So it will be great to learn from your experience in terms of, as an implementer, do you find these models valuable? What's the feasibility that you have seen in your experience over the years? And please.
Thank you, Rajat, and thank you for having me here. I think the way I sort of look at this problem is that, we're talking about two different things. So we talk about financing, which is how do you really make money available for care. But a lot of the conversation around outcomes, etc., is also really about contracting. And contracting is also where in healthcare, especially where the principal agent problem comes in, where the question of how do you really get the bang for your buck comes in. And there are significant issues there around data and benchmarks, right? So in India, for example, we don't really know what outcomes we can expect for what prices, and we just don't have those benchmarks yet. So, and one of the things that we can hope for from ABDM is that we can start collecting some of those benchmarks at a population scale. But I think I've been very fortunate to have really spent my life, adult life in healthcare. And I will maybe talk a little bit about my experiences. And I've been fortunate to play various roles, right? So I started off as a medical student volunteering in Bombay slums, ran primary care clinics in Bombay, ran a clinic for government of Maharashtra and Palghar. And then went on to study public health, and then was an impact investor working in the US and in Nairobi, investing in primary care. And then setting up a telemedicine service, which really started off as a primary care service. But I'll talk about some of the lessons from there, right? And one sort of overarching comment from me is that I would really think about primary care as a horizontal. I'd really want to step away from looking at these verticals. An example that really stands out for me is when I was doing my internship at Gokuldas Tejpal Hospital in Bombay. This was during one of the polio drives, and I was posted in the gynecology ward in the labor room. And I remember having newborn babies and then going to the staff nurse to try and figure out vaccinations, and being told that all the vaccine fridges are stocked with polio because all the other vaccines are being thrown out because it's polio week and we have high numbers to meet. So to me, that's an example of how we can actually create a lot of destruction with some of these vertical programs, which work really well, right? And separately also worked in the polio program, and it was incredible to see how well it was run compared to the rest of the public health system. But one of the things that to me as a primary care physician, I ran clinics in Bombay, was that a majority of the primary care in India is delivered by private primary care physicians, be it MBBS doctors, be it Ayush doctors, be it RMPs or quacks, as you may call them. But fundamentally, the private primary care business model is fully broken, right? Like, so there's not enough money in it for the clinician, and what many clinicians end up resorting to is other ways of making money, right? This might be cuts and commissions. This might be figuring out a way to oversell drugs to patients. There's data around a significant majority of the antibiotic prescriptions in India being unnecessary and irrational, for example. So I think that's sort of one point to consider. The other is that we talk about the urban-rural issue in India, where we actually don't have enough practitioners in rural India. And one of the things that we saw in Africa, especially in Nairobi, when at Acumen, one of the things that we did was that we invested in a chain of nurse-run clinics, and Kenya had a progressive regulation around nurses being allowed to practice, and we essentially helped found an organization called CFW Shops, which is a chain of nurse-run clinics, which now I think is in Kenya, Uganda, Rwanda, and a few other countries. And I think we really need to unlock other healthcare workers in the Indian health system to become frontline primary care workers, which currently we don't do, right? It might be enabling nurses. It could also be getting RMPs to do more and somehow formalizing them, training them up, etc., because they're actually in the communities. I also set up a telemedicine service, which was really started off as a primary care service. And one big lesson for us working in rural UP, rural Maharashtra, was that trust in the system is crucial. So when we would go to rural areas and try and pitch primary preventive telemedicine triage and concierge services, one of the questions one of the remarks we would hear back often was that people don't necessarily care that much about preventive care or primary care, at least not enough to pay out of pocket for it. But they were very worried about what happens when a badi bimari strikes or a bigger ailment strikes. And these, primary, secondary, tertiary, these are all sort of artificial distinctions that we make in our own minds to actually understand the health system better. But from a patient's perspective, I think we should really look at the continuum of care and really building trust across the continuum of care, be it in the public system or in the private system. So those are some sort of big lessons for me that I bring to any of the work that I do now. I do think that the COVID experience is also interesting because if you think about this infectious disease pandemic, a lot of what we saw in COVID was a result of our failure in building good primary care at the grassroots, because that really is what we needed to actually manage the pandemic well and keep people out of the hospital. So to me, those are some key lessons that we should think about. But going back to financing and contracting, I think what India should really enable a lot of, and India is a very large country. It's 1.3 billion people. There'll be a lot of variations. I currently now live in Cochin, and we talk about palliative care and geriatric care because it's a very rapidly aging population. It might not be the same conversation in Bihar. It might not be the same conversation in Rajasthan. So I also think that there needs to be a diversity of models that are actually allowed to flourish in India. So one of the things that I would really hope to see is a lot of full stack primary care services. It could be startups. I think, like Abhishek mentioned earlier, there are a bunch of very interesting startups that are trying to do ambitious things in primary care. It could be public health organizations. It could be nonprofits. But we need to see a lot more happen, a lot of diverse models being then compared apples to apples on outcomes and costs, which we are not seeing today, right? So that's really what I would hope to see from any innovative financing that comes through in primary care. So I'll stop here, Rajat, and I hope I've overshot my time.
Thanks, Ajay. I think great point around trust being so crucial in the system and looking at it as a horizontal I think we always talk about how we can look at primary care as something which is comprehensive, continuous, and coordinated in nature, and not just driven by vertical parameters. So I think great opportunities. I think this also gives us a segue to Krisha to reach out to you because of your experience of, say, working in telehealth-led, technology-led nursing clinics in Maharashtra. And also your Dr. Bhushan and others were talking about result-based financing, outcome-based financing, and your experience of working in DIPS. I think it'll be great to learn from your experience in terms of as a founder of an enterprise called Clinic Didi, and also as social finance manager at British Asian Trust. How do you see the opportunities of these models, right? Are they actually working, or are we actually spending too much time in actually designing them? And it takes a long time for us to see a potential impact or evaluate them. Over to you.
Thanks, Rajat. Firstly, thanks so much for having me on this discussion today. It's lovely to be here at Sankalp again, and surrounded by some absolutely brilliant speakers. So thanks for that, Rajat, and the Sankalp team. So yes, I come from a background of both, having worked in primary care on the ground, setting up tech-enabled nurse-led clinics for many years at ITT, and then Clinic Didi. But in the recent years, I've worked on the ground, working with both public and private sector partners in setting up a pay-for-results partnership, a first of its kind pay-for-results partnership, where the government of India's unit, National Skill Development Corporation, came together with private sector partners to say that we want to move the conversation from paying for outputs to paying for outcomes. And how do we talk about the sticky problems in the livelihood sector? Happy to talk about learnings from both of these experiences today, and how we can think about these learnings in the primary care context. I think taking a step back, blended finance or outcomes-based financing, these are often used interchangeably, but at the heart, blended finance is about bringing in philanthropic capital with private sector capital or public capital to de-risk private capital. Outcomes financing is a subset of that, where the donors or the government want to drive specific outcomes and want to use philanthropic capital as a leverage for that. Some great examples in India already. We've talked about some of these. The Samrit Blended Finance Facility is doing an excellent job. I think they've already raised enormous amount of capital. They've worked through the pandemic, de-risking and supporting innovations on the ground. There's also the Utkrisht Impact Bond, which was aimed at improving quality of care for maternal and child health in primary care clinics in Rajasthan. So if you look at all these examples, Rajat, I think the thing that stands out is what is blended finance currently being used for, and how can it be used, to talk about, to solve for some of the challenges that Dr. Bhushan laid out so beautifully. I think the biggest one that stands out to me is, while blended finance can bring in additional capital, it can act as a platform for innovation. But I think the biggest value add that it can add in the context of primary healthcare is risk sharing and risk shifting. The fact that philanthropic capital can come and de-risk private money, public money, and give more bang for the buck, which Dr. Bhushan talked about. I think that's one of the key things that we can think about in the primary care setup, especially as I think the question now is around viable business model. How do public sector and private sector come together? What are viable business models? Where do we need to de-risk? What are the models in terms of pricing, in terms of procurement? I think these are all great questions that can be answered through blended finance. One example that comes to mind is from the Skill Impact Bond that we helped design while I was at the British Asian Trust. BAT was the organization that helped design and work with both public and private sector partners. I think when you think about the sector where private sector mostly provides innovation and government provides is usually the payer, the risk still sits with the private sector, and often the traditional sources of funding are not available to them. And in a crisis like situation like a pandemic, even the traditional funding which is available at a higher cost may not be available to these innovators. I think that's also true for the healthcare sector, where we have lots of startups. There's a very active, very vibrant startup ecosystem in India, but funding for them is usually either very expensive or not available in the context of primary care. I think one way to think about it is, in the impact bond ecosystem, what in the skill impact bond, what we thought about was, can the government take the initial risk? NSDC came in not as an outcome funder, but as a risk investor, because risk capital was simply not available. They provided early debt, I would want to say, working capital to these skilling providers, and helped de-risk the outcome payers in this case. I think we're seeing a similar model in Samrit, where USAID is providing guaranteed capital, is standing as a guarantor to some of these startups and providing them flexible capital. I think that's one of the main learnings I see, or one of the main roles I see for blended finance. But I think the second part that I really want to talk about is how do public sector and private sector come together? Because that's another key learning from the work that I've done on the ground. While we all keep talking about the innovation that the private sector brings, the fact that private sector is really driving service delivery, working well on quality, etc. I think it's also good to stop and ask, what does the public sector need, to do these things at scale? What kind of support do they need to, improve systems, to improve procurement? And that's another place where I guess tools like impact bonds or blended finance tools in general can come in and allow a platform or allow a closed sandbox to trial a few of these measures, to work within the system to drive that. So I'll stop here. I know I've probably exceeded my time, but I'll stop here and back to you.
I think this is an important point, and I'll come back to that, because this is something that we want to discuss with the larger group as well, around the issue around scale and the pilots that have been done in the past. But I think maybe and Ajay, thank you so much for your patience till that point. But I would love to listen to your thoughts. You have been implementing Desh clinics as a chief operating officer, and in tier 3, tier 4 cities and in rural India, and including IoT enabled devices being integrated into the system. I think many people on the panel till now raised the question around viable business model. I would love to hear your perspective in terms of how these business models can be made viable, and that too at scale. And can innovative financing actually support such an effort? So over to you, Ajay.
Yeah, thank you, Rajat. And it has been a good learning session for me, apart from being as a presenter here. First of all, it is very first question to be asked is, why should somebody get into a rural level clinics as an entrepreneur when somebody has other means of earning good money, as an entrepreneur? So the passion is the core. And when I started around a year back, July 21, I started because I myself went through a pandemic, Corona. And I thought that, if everybody, I'm from Delhi, if in Delhi I could not get a doctor, what could have been a situation in a village, where there is no doctor available? Forget about, the doctor term itself. So the passion is the main thing, and the passion needs to be supported. I liked the statement by Anjana, where she said that profit is difficult to come, but impact has to be, measured. We applied for a seed fund, health seed fund, and 2 rounds of, meetings. And I was dissuaded that why you have entered into this area where there is no profit, So they asked us, that what is the ROI, or how much money you have spent, etc., etc. I said, what do you mean by ROI? It is first year. And as, Ajay and I said that, we are struggling to change the concept from a jhola chhap doctor to a qualified doctor through telemedicine. And the person has an issue that, what will happen if next time I have the same problem? Will the same doctor be available or not? So I'm struggling to capture some of the basic level concept selling on the telemedicine. And somebody is asking me, you don't have ROI, so this is not the good model. I also tried, he was from Bangalore. I also tried and it failed. Now it requires, support, not only in terms of financing, but also moral support that, go and, work for the rural area, because India needs it. So it's a passion, which should drive, and the passion brings, a lot of other things. Let me tell you that, we thought that, we will present something and, to the investor, and we'll get some money. But we created our own internal model also. That, how we are going to get the money, because I am a private entity and it's a for-profit organization. So my business model should not be only dependent on the money coming from outside. It should be dependent on, how we can generate money also. And we thought that there are certain things which we will do at our level, but not everything can be done. So there can be partners who are coming in. Again, Ajay and I said that, the people start thinking that, how do we get money from cuts and commissions? But that's the reality, that otherwise, if I am providing the basic consultation in 25 rupees, I don't think I can feed my doctor or the, infrastructure I'm creating. So here comes the, the blended financing, which you are talking about, that, that how do we get the money? We approached Samrid also, but, we were too young, just 7-8 months old. So, they asked us to wait for some time. We'll approach that. But here the importance is actually from the government side also. There are private players who are interested. I'll stop the sharing now. There are private players who are interested in, supporting the government also. I personally visited many primary health care centers before starting this. And I found that there are lack of resources. Either they are deployed or not available, but people are, not having the adequate supply of the resources which they should be. So the private sector can actually be involved in augmenting this stuff which is already available. So you don't have to create an innovation every time. You have certain things available. For example, I have access to technology. We are talking to some of the people who can provide us, the good IoT-based solution. Schwas is one good one, which is available. There is one guy from IIT Guwahati, they have developed a very small 10,000 rupees, testing machine. But these are the things which we can actually deploy in PHCs also, the government PHCs also. So I don't have to reinvent the wheel, but I actually go and start working with the government and start delivering the results.
So how sustainable, maybe just because in the interest of time, Ajay, how sustainable such a model is in your experience? Is it
in our model or the government blended model?
In your model.
It is sustainable. It is sustainable to a level that it can run and it can meet its cost. So break even is possible. So break even is not a difficult thing. People are ready to pay money. People pay us 500 rupees for the super specialist, which otherwise they have to pay 1,500. So
and is there a demand for services that already exist? Like, do you see a continuous demand?
It requires education. It requires education of the the local people to understand that there is a difference between qualified doctor and there is a difference the other quacks which are available. There's a demand. There's a demand.
Thanks, Ajay, and thanks everyone for actually sharing your thoughts. I think we brought out a lot of critical points, right from the result-based financing, the role of e-vouchers, looking at demand-side schemes instead of supply-side opportunities only, and also the enablers that needs to be created. I think the role for social enterprises is something that we spoke about, and it's evident that there are so many models that exist out there already. I think the first question that I would like to get your inputs is to understand, how do you scale actually? There's so many pilots, models that have been tested that are available for us to look at. What is the right source for us to scale? These are diversified approaches. And also, what is the role that the public system can play in actually helping design these kind of innovative financing models and approaches? I'll open it up to our panel to see any thoughts and reactions that anybody may have on the group to begin with, please.
Rajat, maybe I can start off with your first question, which is how to scale. One of the points that has been coming up throughout for all the speakers has been a lack of data. Evidence generation is extremely important to understand where the problem actually lies in terms of where the healthcare expenditure today is happening, and especially the lack of primary care. Even though people think that lack of primary care doesn't really impact, your overall health, but actually, by the time you catch the things you should be catching in primary care, and they become really serious, and you end up spending a lot more with the catastrophic illness that you're going to face. So, in terms of scale, I really think we need to be able to make good decisions, and those good decisions will only be made if we can capture data. One of the things that I've observed is that while we have data, we have fragmented data, and we also are not able to actually utilize the data to do the kind of studies that we need to do in order to have the decisions that need to be informed. So in terms of scale, I really think that when investors come in, they are looking for a baseline. They're looking to see that there could be an alignment between the funder and the implementer. So having very clear guidelines on what those principles are going to be. And then on top of that, having a 5 or a 10-year plan, which can only be done by an entrepreneur or by an authority if you can have long-term funding view. And so it's very important that when we are talking to funders, bringing the public-private partners together, that we have a long-term view of sustainability. So whether that is procurement of services and products, whether it is building procurement mechanisms for competitiveness over the long term, and also doing smart contracting, where you're not just contracting for 1 year, but contracting for 5 or 10 years, then you can see a long term for what volumes you need, what kind of monies you need, and what kind of implementation programs you're going to be tracking to be able to create that scalability. And in terms of role of public systems, I really think that, I was very struck by what Ajay was saying, which is, really people are going into some of these fields because of their passion. Profitability may not be there, but they are there to make a difference where impact is really required. So I really feel like the first encouragement that has to come from our own people. We have to be encouraging to the people who are doing this work. We have to make sure that if we're having the conversations, that they are about scalability, that they are about their long-term plans and what challenges they are going to face. And I think from a public system standpoint, just creating more transparency in procurement, more transparency in sort of the receivables and reimbursement will go a long way for entrepreneurs. Right now, I can tell you when I talk to entrepreneurs, the biggest challenge that entrepreneurs have is that if they get into healthcare, are they going to receive a grievance addressal process? Are they going to be able to get the reimbursement if they go into the government reimbursement space? And is it going to be done in a timely manner? I think the IT systems which are getting in place now to be able to guide that reimbursement, to create more transparency, we're seeing that in a lot of states coming through, will go a long way. So that's my personal perspective. Thank you.
Thanks, Anjana. I think a couple of important points. It also begs the question, how do you actually create demand? How do you ensure a continuous demand, considering there is so much of shifting consumer behavior as well, which is prevalent in this case? And maybe Dr. Bhushan, if you can, how does that link from the perspective of Ayushman Bharat? I think it's such a wide reach that has been created. It'll be great to hear your thoughts in terms of what's next for Ayushman Bharat. How can Ayushman Bharat play a role in enabling that demand for services going forward?
Well, Ayushman Bharat, I was there for about 3 years, and first year was in planning the scheme and getting it off the ground, 2 years of implementation. And within that short period of 2 years, what I'd seen was that already the demand, of course, it's a demand side scheme where addressing those people who have never used private sector services, at least at the private sector, I mean formal private sector. Of course, as someone mentioned earlier, that they do use private sector services which are informal, as I think someone was calling jhola chaps. But for getting to the private sector, this was the first time many of these families are using private sector services. I give you one example. We were actually putting a lot of pressure on good hospitals in Delhi for ramping up their work for Ayushman Bharat. So one of them is government hospital. I'll now not tell you the name, but it's a very reputed hospital in Delhi. And the director of that hospital once, when I was reviewing the scheme, told me that, what happens that many patients come here and they get the diagnosis here. And for example, if they need bypass surgery or any other surgical or big intervention, when they find out that they are eligible under Ayushman Bharat, they just go to a private hospital and get it done. So I was telling him that, see, this is the reflection on the quality and responsiveness of service that you provide, because if they're going to a private hospital, they're basically voting with their feet, and they're going there. So they're using those private sector services. So there was a creation of demand for private sector services through Ayushman Bharat, because these are 50 crore people who don't have the paying capacity. Now Ayushman Bharat has given them paying capacity, and they can go anywhere that they choose, either public or private. And this public and private mix varies from state to state. In some states, actually, they still prefer to go to public sector, for example, in Tamil Nadu. So there is that demand creation. But one of the key issue, I think someone mentioned, I think it was Anjana, which was mentioning, is the comfort that we have to give to private hospitals, that they'll be paid on time. And here, I think some innovations are in order. One, that government should try out models where they'll pay without asking too many questions, and after payment, if they find that the payment was wrong, then penalize those hospitals in a big way, so that onus is on the hospitals to ensure that they're putting right claims and not resorting to any fraud and abuse. Second thing that I was thinking, and actually we had tried this on, we had discussed this with large number of bankers, was that if banks can provide loan to hospitals based on receivables from Ayushman Bharat. For example, there is a hospital which has 3 or 4 lakhs of receivables from Ayushman Bharat. Backed on that, if loan could be provided by the hospital, because and they can mortgage that receivable in some way, and so at least the hospitals will have that kind of running capital. And this interest payment, if governments are delaying payment, I think so, it's a moral responsibility of government to compensate hospitals for that loss of interest. And actually in our documents, it's very clearly mentioned that if any payments delayed beyond a month, we'll be paying interest to hospitals. So of course, if we are delaying payment not because of any fault of hospital, I think this interest could be paid by the government. Even if the interest is not paid, I think hospitals would welcome this additional cash and liquidity, if because interest rate for, say, example, 6 months won't be that much, and so it will also help. So I think one has to now keep focus on how to give comfort to private hospitals, that by joining Ayushman Bharat, they'll not go under, they'll be compensated for their expenses, and they can still continue to thrive. That is something I think we'll have to focus on. So obviously, there will be huge increase in demand, because this is an untapped area, because large number of these people could never afford to go to private sector. Now they can.
Thanks, Dr. Bhushan. I think the more I hear from all of you, the key that I'm hearing is that we need to have result-based payment systems, not only for the services that we are delivering, but also for the government, or the systems which are actually enabling these kind of contracting, Ajay, as you were saying as well. So I think maybe, Ajay, I'll come to you, and then to have your thoughts around scale-ups. You have been part of many of such models as well, and have seen them grow. How do you scale? Is it, you spoke about diversified, is it and I'm taking a risk of going opposite to what you said. You spoke about horizontal, but I'm asking if there is a need to actually focus on few specific areas within primary care for us to scale it. across a wider area.
I'm assuming the question's to me and not to Mr. Sharma.
No, to you.
Yeah.
Sorry.
Okay. Okay, thanks. No, so I think, so to me, there are a few pieces of primary care that, so that do, from a vertical standpoint need to be solved for, right? So one of it, which I mentioned earlier, is just contracting and everything associated with contracting. Ayushman Bharat has done PMJY has done a great job around contracting, package rates for inpatient care. We don't have a similar framework around contracting for primary care. And especially we don't see anything around sort of population-based contracting, right? So one of the things that we are seeing in global best models is that you really have to start looking at population health management for an empaneled population for a primary care center, as opposed to just looking at the individuals. And we are not really seeing frameworks for that. And we're not seeing that partly because of what I mentioned earlier, right? So there's no good data, there's no good benchmarks around that. So even if you start contracting, you don't really know where to start there. So to me, and there are examples of lots of pilots across the country, currently, and also regulatory sandboxes, right? So for example, the IRD has a regulatory sandbox, which looks at innovative models that are insurance plus. And I know that the regulator has an interest in solving for outpatient care and out-of-pocket payments. So I think one piece to solve as a vertical might just be contracting. The other piece that sort of is critical to me is healthcare workforce, right? So how do you really look at all of the available workforce that we have in the country? You look at individual primary care doctors, public primary care providers, nurses, and frankly, the RMPs of the Chola Chaps, right? And how do you really look at everybody who's there? And how do you really figure out what kind of skill augmentation do you need to do? How do you position this workforce to deliver the kind of care that we need to get? The last piece is around care pathways and clinical models, right? And we are also not seeing enough of that, enough innovation there, enough guideline setting there happening. So what is really good primary care? What is good tech-enabled primary care? And these are all problems that we all grapple with in multiple forums. But I think those three to me would be sort of verticals to solve that enable this horizontal to come across, right? So that's really some quick thoughts from me here.
Thank you.
Rajat, I just want to add one point on what Vijay talked about. If you think about the protocolization of care and something that organizations like NICE have done in the UK, I really feel like that's what India needs. We cannot let 1,000 flowers bloom. There needs to be evidence-based protocolization, and therefore you need institution building like NICE and have a NICE equivalent in India. And that's the kind of reform and institutions we need for primary care.
Yeah, and I absolutely agree, and it needs to be institutionalized very, very formally, right? And NICE is for a much smaller population, so we need to do this at a greater scale, obviously.
So Rajat, I had one point. Primary care. My experience is OPD insurance is one of the important things we need to bring in. We found that if we have a good OPD insurance, the load to the hospitals is going to be lesser. If we get into the primary care or the preventive care, we have actually started, and I think in a month or two I'll have I'm working with an insurance company, and we'll have the OPD insurance also built in. If we are able to bring that, I think more people will come. I'm responding to your demand side. And there's an adequate demand which is available, but it is that people do not want to pay for prescription. People want to pay only for the medicine. So if we have the OPD insurance available, it will actually create a good demand and lesser load to the hospitals later.
Thank you. And considering that we are close to our time, I would like to maybe any closing thoughts from any one of you to share that what would you like our audience to go home today with? How is the impression around the opportunity for innovative financing? Should we be hopeful in terms of where we are, or what do we need to do more?
Definitely hopeful, I would say, Rajat, given what we've heard from everyone today. I think one thing to take away is what Abhishek said, stuck with me. It's a tool at the end of the day. Financing will always be a tool to the outcome we want to way, right? We cannot be a hammer looking for a nail, but if we design carefully, if we design with clear standards, if we work very closely with principles of scale early on, I think definitely I'm optimistic.
Yeah, and if I can quickly come in, Rajat, we should also remember that we're in the middle of this epidemiological shift, where a majority of morbidity and mortality in India is more and more going to come from non-communicable diseases. Our health issues are not going to be solved by more bypass surgeries and dialysis machines. It's only going to be solved by primary and preventive care. If we are not able to solve this, the healthcare inflation and the cost of delivering healthcare to a population that will rapidly start aging will bankrupt this country, right? So this is a problem that needs to be solved very, very quickly.
Thanks, Ajay.
There's only one thing to add, Rajat, which is around ABDM. When we think about the timing, the kind of population management approaches that Ajay is referring to in the context of NCDs, etc., is just not possible till you have some kind of registries, if you will. So I think ABDM allows all of those use cases to be built upon, which was just not possible, 5-6 years back. I also feel actually that it will help the adoption of ABDM as well, which is at some level also an objective unto itself, but it just lacks those strong use cases. So it really goes hand in hand.
I would like to take the opportunity to thank all of you. I think it was great to hear your thoughts and the opportunities that you shared and the ideas with which we can actually build. I think the role around areas, I think Ajay, you brought out some great points around vertical programming in terms of contracting, health workforce, things that we need to focus on and bring in efficiencies around. And Dr. Bhushan and others shared about the role for demand side financing and how we can actually generate more demand. The point, there are also opportunities and areas we're seeing around the role for social enterprises, which are coming in this space. And that creates more and more partnership opportunities going forward. And technology, I think with ABDM and the things that we shared, we all agree is the next best thing that could have happened to us, right, going forward. So I'll take the opportunity to thank all of you and for taking time out and sharing your thoughts and experience with us. Thank you. Thank you.
Thank you.
Thank you.
Thanks, everyone.
Thank you.
Thank you all.
Thank you, everyone.